today and joining us for this webinar. This is a really current hot topic, talking about dysautonomia and POTS even more so than in the past, just because of what we've all seen in the media lately with awareness about dysautonomia maybe being present in some people in the long haulers post-COVID. And so there's just more traveling around. I think we've all seen a push on social media with more questions in our support groups. So I'm happy to help. And I did recently at the 2020 virtual dysautonomia meeting, I spoke also about exercise with dysautonomia and POTS. And so this is a little bit of a follow-up on that. I am going to review a couple of things just so that we have, I know not everyone that's present today attended the meeting in October, so I'm going to help catch everybody up and try to get us all in the same place. I do just want to talk about the fact that I am a physical therapist, and so I will talk a little bit about the role of physical therapist on the healthcare spectrum of how we can help you if you're struggling with being able to exercise with POTS and dysautonomia, and to address exercise intolerance. Can you advance, Kirsten? Thanks. And just as a disclosure, this is obviously a quick webinar, and so it's outside the scope of this meeting for me to be able to give anyone personal advice on how exercise might work for you. And that if you are having any particular problems, I highly recommend that you seek support with a healthcare provider. And that exercise really should be independently and individually dosed, and that your personal health factors or any comorbidities have a big impact on how you tolerate exercise. And so getting outside help can be essential, really, if you want to be successful. Next slide. So just really generally speaking, I'm not going to get into all the physiology of how dysautonomia and POTS work and why you should exercise, but I think generally we recognize that if we're sedentary and we're not doing as much because we don't really feel very well, then our stroke volume may be slightly less. We're not pumping out as much through our heart, and with POTS or dysautonomia, we tend to have an overriding sympathetic tone that puts us in that fight or flight response, which is not a great way to start exercise. And there's this whole myth that, you know, POTS is because of deconditioning, but most of us were very, very active and involved before we got POTS. And so it's really the post-development of dysautonomia or POTS that makes us more sedentary and leads to deconditioning over time. And so we want to reverse that and prevent it from getting too bad. And we'd obviously like to get back to what it is that we do, whether you're a parent or a student or an employee somewhere, or you're a caregiver, whatever it is that you need to do, we want to get you back to what it is that's important to you. If you climb mountains, then we want to climb mountains. Next slide. So what I'll say here is that if you are lucky enough to have a kind of milder version of dysautonomia, or what I kind of sometimes refer to as a vanilla POTS, then the standard recommendations that probably most of you have heard from any frontline healthcare provider that you've gone to is that you need to exercise, you need to hydrate really well. And hydration is not strictly water, it's water mixed with sometimes electrolytes, because we don't want to be underhydrated. We don't want to have too much water because that can create other types of problems. We now to mix that up with some sodium intake. A lot of people will tell you to wear compression garments anywhere from knee socks to all the way up to an abdominal binder, that it might help with some of the fluid return in your legs. Some people advocate of elevating the head of the bed. And we do know that there are exercise training protocols or programs that you might be given in paper, and those are usually stem from the original studies that were done in Dallas from the Levine protocol, or the modified Children's Hospital of Philadelphia version at CHOP, which is a slightly longer program because we started to recognize in research that not everybody got better in the length of time that the original Levine protocol was written for. And we have to remember that the Levine protocol was written for a research study, so we can all just walk in and do that same protocol. The CHOPS exercise program tries to extend that to more of like an 8-month program mixed in with a bunch of core strengthening exercises in combination with cardiovascular, and even addresses some things related to balance and vestibular dysfunction. And so we've learned a lot along the way. There's 2 pictures that will populate if you hit the button, Kirsten. So this is part of my story. This is my older daughter who acquired POTS when she was 15, and she's now almost 20, which is crazy. But this was her, and you can see she's doing this. She's got the compression socks on. We had a rowing machine in the house. She doesn't look like she feels particularly fantastic. And this was probably, I don't know, maybe number 3 attempt of doing exercise, which was, again, another failure. And if you hit the button again, there'll be another picture that pops up. And so this was a year after this rowing machine picture. We still had not made progress. And so we got some advanced autonomic testing done, looking at whether or not she was having signs of autonomic neuropathy or small fiber neuropathy or anything else that could be contributing to her regular failure with exercise. So I understand why you're here today. Next slide. So this is just contact information for you. If you want information about the Levine protocol, they will not disseminate it to individuals who have POTS or dysautonomia, but if you have a healthcare provider and you have them contact the office on your behalf, they will issue it to your healthcare provider. They do that because they would like you to have some guidance in doing exercise and someone to check in with if it's not going how it should. The CHOP modified exercise program is available on the Dysautonomia International website, and so you can freely access that, and it has calendar charts to help kind of guide you in your exercise protocol. If you find that you can't figure this out and you're struggling, I would highly recommend that you find a qualified healthcare provider, and I use that term qualified because qualified it can be a physical therapist. It doesn't have to be. There could be people in your community that have personal experience with this. You might know a trainer. There are various people who have chosen to become more engaged and more involved in learning about POTS and dysautonomia. And so what you need is a partner that can help you figure out why you may not be exercising hard enough or why you're exercising too hard, and either way you're not making progress. Or if there are medical conditions that you're not recognizing that need more medical oversight so that you can start to become more successful, then you need some people that you can partner with. And you could be in a rural area. You may just not have access to financial resources to be able to do what you want to do. So a qualified healthcare partner might look different to different people. Next slide. So before the Dysautonomia International virtual meeting in October, I sent out a Google poll with Lauren's help because I wanted to really understand you as the audience a little bit more, whether I had healthcare providers coming to the conference or people who have dysautonomia and POTS. And I wanted to know, what do you think is the problem? Why do you struggle with exercise intolerance? And so these were kind of like the top 10 list of reasons why people failed. And we're going to go into this a little bit more. And for those of you who attended the conference, you've seen this before, but I just want to touch on it so we have a starting point. Some people talk about fatigue after exercise or even during the exercise so that they just feel like they can't keep going. Lightheadedness is a problem, shortness of breath. And I think it's important to recognize if it's happening while you're exercising or if you feel good while you're exercising and then you stop and you get kind of this like hangover or aftermath of exercise that creates these symptoms. Next slide. So again, if we get back to that group of people that are actually at the point of doing cardiovascular exercise, I want to try and reach all of you here tonight a little bit. So some people are on exercise equipment, whether you're walking on a treadmill, if you're on a recumbent or an upright bike, if you're on a rowing machine, if you're swimming in a pool, you might be doing cardiovascular exercise training where you need to be in a target heart rate zone. So if you use a Levine protocol or the CHOP modified protocol, there are some ways to take your heart rate at rest and do some calculations that are in those programs that help you to figure out what should be your range of where your heart rate needs to be. Now, just as an example, my daughter that you saw on the rowing machine before, if she was upright, her heart rate was around 125, but her maximal heart rate that she could do in order to stay within this kind of yellow zone of fairly light work was she couldn't go above 140 or she would start to get into more symptoms. So 125 to 140, I'm a physical therapist. There's not a lot of things that you can do where you can only change your heartbeat by 15 beats per minute. And that's what the cardiologist told us. He said, your hardest job is going to be, what can she do to go between 125 and 140, but not over 140, because then she'll start to feel really gross. So playing around a little bit with that is a starting point. If you are that person that has a little bit more bandwidth to your heart rate training program, then you can start to play with this. This is a Borg scale, or rate of perceived exertion. So it's how hard do you perceive you're working. And we kind of want to stay, you warm up a little bit. If you're symptomatic all the time, then your warm up is going to feel still a little like you have a little bit of light work doing that warm up, and maybe even getting into hard, just warming up for 30 to 60 seconds. Your base pace should be somewhat hard. And so for a while, you want to kind of stay in that range and not go too far beyond that, or you're going to immediately kick yourself back up into lots and lots of symptoms. Next slide. Oh, this is sad. It didn't all populate. So another way to look at that is a visual analog scale. And so the box that you're seeing is probably somebody that still has kind of like a grimace smile, not a flat face yet. And so go ahead and click the button one more time, please, Kirsten. And so again, getting into this idea of the yellow zone being like a little bit of symptoms coming on, we want to kind of push the window a little bit and make you a little bit symptomatic, but then we want you to be able to calm it right back down. We want you to have a control switch. So next slide. This is what I use when I'm teaching people all the time in rehab, is I want you to think about all of your symptoms. I don't care if it's fatigue, headache, nausea, dizziness, shortness of breath. Think about them as a indicator on this dimmer light switch. And if I asked you, Kirsten, to advance one more time, please. So what is your background noise? What is your kind of present hum? Like if somebody didn't turn the light switch off all the way, is there a hum that's always present there? It could be a sense of just feeling off. It could be a sense of feeling foggy-headed. It could be a sense of just mild nausea, whatever your background hum is. And usually that registers a little bit lower than where this dimmer light is positioned. Next slide, Kirsten, or next advance. And so the next question is, should you even provoke yourself right now? If the dimmer switch was up higher than what is in this picture, then I would say you probably shouldn't exercise. You should only try and turn your dimmer switch down so that your background noise is resting at a lower level. Next little point. And then knowing, so how do you even do that? What works for you? If you know that you need to turn your switch down, is it lying in a dark room for a little while? Is it putting weights on your body to help give you some awareness of where your body is in space? Is it drinking fluids? Is it eating a little bit of salt? What kinds of things can you do to help turn down some of that background noise? Next point. And then every day, as you set yourself up to exercise, this is what you want to determine, because no 2 days are alike. And this is one of the biggest problems with conditions similar to dysautonomia in POTS, is that when you wake up and sit on the edge of the bed every single morning, you don't wake up with the same brain every day. Your level of brain fog, fatigue, dizziness, headache, neck pain, whatever, it's a different starting point every day. So you kind of have to do this personal inventory of, where am I even starting? What can my body handle? What can I handle? And what's my zone that I can travel in? So if that dimmer switch is here, your exercise should only turn it up a little, but then you need to be able to turn it right back down. So on your handouts, there's going to be a 5th point that I added to the slide that for whatever reason is not populating. And that is that within 15 minutes of, actually you can try and click one more time again. I don't know if it'll show up. Nope. So within 15 minutes of exercise, if your dimmer switch can't come back down, then you probably did a little too much, and you may or may not need support in helping figure out how to modulate that exercise level. Next slide. So we're getting now out of that window of people that just happen to be so lucky that they can already be doing cardiovascular exercise, because we all know that not everybody can do that. So if you're having what we call exercise intolerance, then you're the kind of person that goes to the doctor's office and the doctor or whoever it is keeps saying, why aren't you exercising? Why aren't you walking? Why aren't you need to get out of bed? You need to move more. You need to do A, B, C. You need to move. But you know that you fail every time you do it. You saw my daughter on the rowing machine. We failed a gazillion times, and here I am, a physical therapist at home. I've worked in traumatic brain injury my entire career, and I couldn't figure out how to help her exercise. So what does exercise intolerance mean? There's that concept too of like, do you have to work through it? Is it the no pain, no gain concept? Or do you have to make yourself feel horrible and then pay for it afterwards? To me, exercise intolerance means that you've repeatedly tried something and you're repeatedly failing and you don't know why. You can't tolerate being upright, your heart rate's going too high, you're getting a mass amount of symptoms that you don't know how to manage, and you don't have the right tools to get to the next point. So you need help. You need to partner with somebody to help try and get you some support. Next slide. So there's a gazillion things, right, that could be going on, and we all know that there's comorbidities associated with dysautonomia and POTS. My personal belief is that a lot of these things have an underlying problem that's related to neuroinflammation that we really don't understand the pathophysiology of, but we're all in the different Facebook and social media groups, and everybody seems to have more than one diagnosis. So whatever your flavor of what's going on, it can be complicated, but again, awareness is increasing, and we're here to try and help. I'm here to try and help physical therapists and other healthcare providers step it up. We got to be able to partner with you, help you to get better. Next slide. So just as an example, I just pulled this article up 2 days ago. It's a new publication about the fact that, and this is in, I think, systemic mastocytosis, so it's not completely applicable to people who have mast cell activation or that, but there is elevation in histamine response for people following exercise. So we've known and we've heard that exercise itself can be a mast cell trigger. So sometimes, depending on how activated your mast cell disease situation might be, or your allergy profile, or whatever you might have going on, and this was the case for my daughter, every time she tried to exercise, we had system-wide mast cell response that made her ability to tolerate exercise impossible. And so until we got good control over her mast cell issues, she wasn't able to engage in this. And so again, just showing you there's more things coming out. This was just published. I can't even access the full article right now because it's not released in a format that I can get. Next slide. We also know that there's a propensity of people to have connective tissue disorders and hypermobility syndromes. Again, this is within the bandwidth of physical therapy to be able to help. The Muldowney, Kevin and his wife have done lots of work in the Rhode Island area, and they have trained a lot of different people around the country to work on some key stabilization, joint protection, pain reduction techniques that help work with people who have EDS or hypermobility spectrum disorders. And so again, if you're struggling with certain aspects of exercise because you can't stabilize, then you certainly need some level of guidance to help you be successful. Next slide. So another component that goes with that is this concept of fatigue. We talk about during exercise and after exercise, it's fatigue inducing. So there's two general types of fatigue. One is a peripheral neuromuscular fatigue, and that's what we think of as like a Charlie horse cramp, or it's described as you can't produce enough force. Like we talk about the 10 repetition maximum in exercise, where if you're sitting on, let's say, a leg extension machine, to determine how much weight you can lift, sometimes they'll say, well, how many pounds can you lift 10 times efficiently? And if you're fatiguing peripherally, then by the time you get to number 10, you might not be able to lift the entire weight stack that you started with. So that would be fatigue of the muscle and an inability to produce enough force to lift that weight. That can also be related to endurance. It's usually at a more cellular level, where there may be a problem with cellular metabolism, with energy, ATP, if you remember your old biology days, and then also just like lactic acid buildup and those kinds of things happen in the peripheral muscle tissue. When we talk about central fatigue, that is when you really have like passed the point of no return, because now you're in brain fog territory, you're in sensory processing issues where you're getting the dizziness, you're getting like head pressure, headache, lots of overlay of different symptoms that are really hard to quickly contain. And then I think that there may be some spectrum attached to that, where we have a subset of people that may or may not have more of a profile that tends towards chronic fatigue and myalgic encephalomyelitis, where you might have the post-exertional malaise that is an outrageous kind of severe response to exercise, where people end up bedridden after they try to do some of these exercise programs. So just having an awareness of what different types of fatigue look like, so that you can have effective language and communication with healthcare providers, and being cautious about how you approach exercise. Next slide. So what we look at in the brain world in neurorehabilitation and for the complex POTS patient or dysautonomic patient, which could include anything like an overlay with Parkinson's disease. A lot of people with Parkinson's have dysautonomia. And so we see this in many different flavors in neurorehabilitation. We see it post-concussion. And so this is all very, very familiar neurorehabilitation terminology and territory. So there's this kind of cycle that happens, if you will, where as I'm sitting here, my inner ear and my eyeballs are telling me a lot of information. My inner ear tells me that my head is still while I'm talking to you. If I was moving my head around, then my inner ear would tell me that my head is moving, or it would control the fact that my head was moving to help me keep my eyes focused on you. If my inner ear wasn't working well, my eyes would be darting back and forth with my head while I was turning my head. But if I can stare at my finger and keep my eyes still, then my inner ear is communicating with my eyes. I can look beyond my computer screen and I can see a door frame that gives me information about vertical lines and horizontal lines so that I'm visually oriented to my space. I can feel the surface of the chair that I'm sitting in. And so I can feel the steadiness of my body. If those things are not accurate, if those signals from my peripheral organs, my inner ear, my vision, and my joint sensors of my body, if that's not accurate, then the sensory information traveling from my nerves up and feeding into my brain are sending a jumbled puzzle to my brain. And the output of that jumbled puzzle is any of your symptoms. It can be brain fog, it can be dizziness, it can be nausea. Kirsten, you can just hit the advance button for a little animation thing to, or signal to come up. So this is where the sensory input creates this kind of cloud of your brain doesn't really know what's happening. And so it changes your motor response plan. So if you feel unsteady because of all these things that are coming in, then you're going to guard your movement pattern. You're not going to go moving your head all over the place if it makes you dizzy to do that. You're going to lock your head still in one position and not move it, and that's going to make your neck stiff. If you feel like the background kind of blurs and moves on you, you're not going to move as quickly. You're going to touch things to try and check in about where you are in space, and you're not going to move as fluidly or as automatically. And so your motor behavior changes over time. And so this cycle just keeps happening. And if you're laying in bed because you're deconditioned and you're feeling lousy, then you're not stimulating your inner ear and you're not exposing yourself to different environments. And so all of this function just becomes really, really simplified, and you start to adapt the way you move. My job as a physical therapist is to help figure out for people why they're doing that and to help break those patterns. We call them maladaptation because they stop your normal movement, and we want to restore normal automatic movement. And so that's what we do with people after brain injury, after concussion, and even after just an inner ear problem, like getting an ear infection. You may have heard the term labyrinthitis, where you get an infection of your inner ear and it throws your signals off. And sometimes you just need rehabilitation after that. Well, the same pathways that control all that inner ear function overlap with your autonomic nervous system. So it makes sense that there is some disruption of the sensory motor processing when you have POTS or dysautonomia. Next slide. So if we go back to what that top 10 list was of what people perceive that makes them feel yucky when they're not tolerating exercise well, it's the same things that come up with sensory processing. So I wrote you a little list here and bolded some of the top 10 items were either during or after exercise. Fatigue, headache, and dizziness were some of the top complaints. And those are some of the most common symptoms that go along with altered sensory processing. I'm pretty certain that there's a number of you in the audience that have POTS or dysautonomia that would also say that you are sensitive to light, touch, sound, noise. I couldn't touch my daughter's back to just tell her I loved her and rub her back for probably 2.5, close to 3 years, because she had some sensory neuropathy and she could not stand to be touched. That's pretty common with this. I will maybe give you hope and tell you that now it's not a problem at all. So some of these things can be resolved and extinguished with hard work over time with different therapeutic strategies. But a lot of it is just helping to re-normalize the sensory processing in the brain. Next slide. So for any of you that attended the talk in October, this was one of my key slides, and I think it's really, really important. So again, getting back to the concept that if you feel gross and you're in bed or you're less active for an extended period of time, your posture changes. Our muscles shorten, and it's called adaptive shortening when you're sitting in a certain position all the time. So if I rotate my chair just a little bit here for you, and if I just sit like this all the time, because that's comfortable for me, then the muscles here in the back of my neck are going to shorten over time, and it's going to make it hard for me to straighten up a little bit and bring my head into a more optimal position against gravity. So that's what this drawing is showing us. It shows us that when our shoulders get rounded and our chin kind of jets forward and we shorten those muscles on the back side of the spine, that really interferes with our overall orientation. If you look at the vertical yellow line, that is the line of gravity. So her head is forward of gravity and her shoulder blades are behind gravity, and that's kind of how she's keeping her balance. She is stacking her body parts on top of each other in order to stay upright, but they're not in optimal alignment, and she's probably not moving anywhere fast. And so when she does move, she's going to be a little bit disoriented. If I turn my chair again to be a little bit more like she is, if I'm like this all the time, then if I just look up the littlest bit, my head doesn't have much of anywhere left to go. So if I was standing in my kitchen and I reached up to get a coffee cup out of the countertop, I might feel like I'm going to topple over backwards because I'm so far out of that gravitational line that it's really disorienting, and it gives you almost a visual vertigo and makes you feel like you're going to lose your balance backwards. It causes neck pain. It makes you tired because you're holding up a weight of a bowling ball on top of a popsicle stick of a neck that is weak and deconditioned. It can certainly give you headaches because the muscles here on the back of your neck get very tight, and there's a big fat nerve that runs like right in the middle of those muscles, your suboccipital nerve, and it can cause headaches that kind of wrap up around and feel like they're pulling on the back side of your eyeball. So there's lots of different types of headaches you can get, but obviously there's a lot going on in this picture, and so I'm going to break down little parts of it to talk to you about how you can work with your fatigue, with your posture, to help get yourself a little bit more prepped and ready to be able to tolerate exercise better. Next slide. So this is a picture of my second child who also has dysautonomia, but she does not have POTS. She has more of just periodic syncope. She has typically extremely low blood pressure, extremely low blood sugar. She gets abdominal migraines. And she's kind of thankfully grown out of it just a little bit. Her underlying cause was a concussion when she was 8 years old. She is 16, and we are just getting out of like 8 years of post-concussive recovery, and this is my primary job. So it was mind-blowing. This was a no big deal concussion where she was at soccer practice, and it just so happened that a soccer ball bounced off of her knee and went like right up the line of her nose. She has now had eye surgery because she had a congenital misattachment of two of her eye muscles that gave her double vision, and she had learned how to suppress an eye before the concussion, and then the concussion didn't allow her to suppress anymore. She just finally last year had sinus surgery because the original hit did damage to her sinus system. And this morning she had her wisdom teeth out. So I was just like all the rest of you who get on Facebook in the morning of your wisdom tooth surgery and say, wish me luck. We are doing this again. We're getting our extra fluids, and I have my stash of anesthesia medications that I would like to advocate for. And you know, we had it all set up today. So she thankfully is resting in bed right now and probably will be more uncomfortable tomorrow than she is today. But if you look at these pictures, the picture of her on the left sitting in bed, she's in that shortened neck, jutted head forward position, probably streaming, right? Netflix. Our kids like to get lost in a show to help pass time, to cope with the way they feel. So I show that position because it's one of many positions that you or your children might want to be in as a resting, comfortable position, but those neck muscles are going to get adaptively shortened in that position. So for a short bit of time, that might be a good position. But then moving into these other positions, and ideally the third picture with the green check mark, where her hips are scooted a little bit more forward, So her upper back can be a little bit more straight and her neck muscles can be a little bit more elongated with her chin down. You notice that in all of the pictures, I have her with her laptop positioned at a lower level so that her gaze is downward, so that her neck can be a little bit elongated and stretched. If you have a ceiling mounted screen that your child or you are watching, that is going to encourage you to be in this position. And I'll ask you for a moment to put your own head in this position. And you can tell it's changed my speaking voice. It's not easy to talk like this. It's also very difficult to swallow. And so if you're walking around and sitting like this all the time, it's horrible for your neck. And so if you bring your head forward and even down a little bit, it's much easier to swallow and it opens up your whole voice and makes things smoother. It helps you breathe better with the appropriate breathing muscles, so you're not using your neck muscles as much to breathe, but you can breathe from your diaphragm. Next slide. Lying on her side, her preference when I asked her to lie down was in the picture to your left on the screen. And so her neck is kind of cocked funny in a sideways position, which might work well for a short period of time. But when we aren't moving really well, it's really easy to get locked facets. And the facets are those hooks that are on the back side of your vertebrae, and they can kind of pinch one of your sections in your vertebral spine there. And people that's when they wake up and they're like, oh my gosh, I can't tilt or rotate my head to the side. So in the second picture, I just have her with her pillows a little bit more under her to support her head in a slightly better position. You can tip the computer screen then if you want to make it more level. And really just encourage people to change their position every 30 minutes or so while they're awake, so that they're not getting too tight in any one location. Next slide. Again, sitting at a desk if kids are doing a lot more online studying and work right now. And so trying to get the perfect chair, desk, computer monitor height set up so that posture is good for studying and learning. So again, in the left picture, she's got the slumped rounded shoulders, her chin is forward, and she's got that adaptive shortening in her neck. That was how she chose to sit down when I asked her to sit in a chair, and she said, how else would I sit? So I had her scoot her hips forward a little bit, and I had her bring her chin back just a little to lengthen up the back of her neck. And now she's again down gazing just a little bit at the computer screen. So you can use, different things to raise the screen up or down depending on what you're trying to do. But then keyboard can also be a problem, because if they put their hands up on the keyboard, you don't want them raising their shoulders, because that will make the neck more tight as well. So having a keyboard that can be down low, and I personally find that that works well if the keyboard is actually even in your lap, because then you're not raising up to get onto a table surface. Next slide. And then sitting on a ball. So she was sitting in a chair, which is a nice firm surface for really good orientation. If you need joint proprioceptive feedback, which is that awareness of where your body is in space, if she knows that really well and she's able to sit on a ball, then you can do that for an altered position and the ability to kind of move and wiggle a little bit. There are reasons why some people like to be on a firm surface and reasons why people like to be on a moving surface, and that's worthy of a discussion with a healthcare provider that can help make you that right decision for, again, that sensory processing. There are some goods and bads to both scenarios. But I think what you can see here in this picture is that she sat down again automatically in the left picture frame, and then I had her roll her hips forward a little bit, and now her feet are more out in front of her, so she can slide her heels back a little, and then she has more ability to flex and extend her knees and roll herself forward and back and change the orientation of her pelvis, and then she can create a little bit more lumbar extension like I'm kind of showing here. So if she was to come up, and you can do pelvic kind of clockwork sitting on the ball, changing the orientation of your spine and the movement through your neck as just like a self-mobilizing kind of an exercise just to get things moving. Next slide. So because she is my child with dysautonomia and not POTS, and her dysautonomia tends to be more of a orthostatic intolerance with low blood pressure, the zero gravity chair is our friend. And so we keep this outside, but we frequently bring it inside when she's not feeling well. She has a weighted blanket on top of her to help herself feel a little bit more grounded. And the nice thing about the zero gravity chair is that you can just gradually tilt it up and tilt it back down. So she's either reclined or in some degree of recline, and then fully sitting, so that you can gradually help your children or loved one learn how to tolerate the effect of gravity and regulate their blood pressure and their heart rate. So it doesn't have to be for an hour. It can be for 10 minutes. It can be for 2 minutes. And you can change it in varying degrees throughout the day. If you have the person that needs to be in a dark room in a cave because they're sensory averse, this can be a desensitization program where for a certain amount of time every day, you can still come into a different kind of darker room with the blinds closed or whatever, and progressively open up into more family space so that you can have a little bit more engagement with the family, being able to watch a common screen so that you can have dialogue about what's happening in a show so that you're not so isolated. Isolation is really, really hard. My rule with my kids was you can watch Netflix all you want, but we have to watch it together so that we can laugh at the episodes together and have conversation about it so that you're not just in a zone independently watching a show. Next slide. So in the CHOP exercise program, there are a series of pictures like this one on the left where a therapist is showing you some technique and doing some supine exercises. So we're switching from resting positions to now exercise positions. So we were in bed first, and now we're talking about how to just lay on the floor and exercise. So these are aimed at working on core work. They should 100% be aimed at working on breath control. There are a gazillion YouTube videos that you could watch on how to do a home exercise program. You could spend all day long trying to find the right one for you. If it speaks to you, that is really fantastic. Not everybody who posts an exercise video will talk to you about breathing. It's a really, really, really important part of recruiting muscle to kind of slowly engage the muscle and slowly release the muscle, maybe over a multiple beat count, and to make sure that you're taking a breath. Someone recently posted in the Facebook group this link to the a POTS exercise blog, I think, out of the UK, and I looked at some of the videos and they were actually quite nice. So just included that there for your reference if you're interested. What I'm showing you on the right side, this is my older POTS daughter who was home from college feeling quite well, and I asked her to help me make some pictures for a presentation that could show some of the exercises that she used to do when she felt really, really gross and she was locked in her bedroom and she wouldn't let me come in to watch her exercise because she didn't want me to see what she was doing. So she went through a run through of the types of things that she used to do. And I am a quality control police officer when I see people exercise, and so my eyes go right to the problem. So what I will draw your attention to is that if you notice the lady on the left, her abs are nice and tight and she's all tucked in and she's lifting her head up and her form is really great. Well, when you look at my daughter, her abs are distended because the exercise is too hard. She can't control them and her back is probably arched off the floor, and you can see these big muscles right here. They're jumping out on the side of her neck because she's really straining to lift her head up off the floor and to use her abs. So a different way to look at this would be in the second picture where her head is actually resting on the floor. She's doing a bridge and she's only lifting one leg instead of both. So that would be maybe an adaptation of doing something different. Similarly, with the exercise in the first picture, she could leave her head down and just lift one leg at a time, or maybe just put her leg down entirely and keep her legs down. This exercise is actually easier if she lifts her legs higher up than if she keeps them in the position that she's in. So sometimes just having a consultation with somebody to say, hey, can you give me some tips on like where to start? Like, how high is too high? How many repetitions is too many repetitions? Can you look at my form and tell me where maybe I'm going wrong? Because if she exercised like that top picture multiple times, she's probably going to get too sore and fatigued and frustrated, maybe short of breath, and it might kick up some other things, some neck pain, some headache, who knows? Next slide. So flipping over on your stomach is always a fantastic idea because we spend our entire day doing front side exercise. So we lay in bed on our back and we sit up all day, but we don't go up from our back. That's kind of different and weird, and our body doesn't really go that way. So we don't have much opportunity to work our extensors. We sit in a chair and we're flexed. So extending is really, really, really important and helpful. This really works on shoulder motion and the shoulder blade being able to glide the way it needs to glide on the rib cage for effective shoulder motion. And for anybody with joint hypermobility, this is a problem. And so really working on stabilization exercises, trying to stabilize the scapula on the rib cage is really, really important. Next slide. From there, you can move into hands and knees, or what we call quadruped, or going into a plank position. This is another individual who is literally just working on trying to lift her head as one unit while she's in a plank rather than curling up like this. So she could rotate through like the joint axis of my AirPods, or she can originate the motion from her seventh cervical spine here, where it's more lifting the head as a unit. It's a little bit hard for me to demonstrate that while I'm talking to you, but she's trying to keep the back of her neck there nice and straight. I tell people it's like you are going to the hair salon and somebody's going to shave like right at your hairline. You don't want to get nicked. So you're trying to really lengthen that back of your spine. Next slide. She's being progressed at this point to where she's sitting upright in a chair. And what I have her doing, she has a laser light on her forehead and there's a target on the wall. And so she's trying to learn where her head is in space, which is really, really important. And so with her eyes closed, she starts with the laser beam in the middle and she just turns her head to the right 3 times in a row with her eyes closed, and she sees if she's able to come back into the target. And then she does the same thing to the left. Now, she had a problem with her neck on one side, and so she was off center. She would always come back off center. And so the retraining is learning how to find where middle is again. Next slide. So now if we go back to this whole idea of cardiovascular exercise and how do I get on a rowing machine? How do I get on a treadmill and tolerate what I'm doing? If you start in a bad postural position, it's likely that you will fail. You're going to get way too many symptoms. And if you can't just hold the weight of your head against gravity sitting in a regular chair, you're not going to be able to do it walking on a treadmill or rowing on a rowing machine. So if you look at the picture on the right, again, my older daughter doing her, this is her rowing 4 years later. She looks much better, but she still prefers to do a short pull pattern. These pictures are not staged. This is her actual current recruitment pattern. So she looks good if she does a short row. When I asked her to do a longer row where she really kind of pushed out with her legs first and then did a big pull with her arms, look at how her shoulders go up into her ears and she just can't control the motion quite so well. She hasn't been as diligent with her exercises recently, and so she's back in a slightly less optimal state. But that doesn't mean that she's not flaring in POTS right now. She's going to college. She's functioning really well. She's out of state, but she's been in quarantine a lot, and with COVID, she doesn't have a place to exercise, so it's been a little harder. But I just want you to be able to see the difference between high quality exercise and lesser quality exercise, because in the picture on the left, she could probably exercise longer intervals and even not make her dimmer switch light go as volatilely up and down. Whereas in the picture on the right, she's probably going to fatigue, get short of breath, and feel achy after that workout. Next slide. This is just a picture of me showing you what it looks like to be on a higher level piece of equipment, because there are some people in this audience that are able to do that. So this is on an elliptical machine. This is a huge soapbox that I have. When you go to a gym or you work out on exercise equipment, you need to be very cognizant of where the monitor is that's giving you information about your workout, or a TV screen. This is optimal alignment to where I can have my neck nice and straight and I'm looking down at the information that's being given to me. If you look at the next picture on the top right, the setup that I have in my room is that I can look down at the monitor, or if I look past it, the TV is set really low. Now, I choose not to watch TV, but sometimes my husband might turn on a football game. That's a lot of visual stuff going on. But that line of vision with that pink arrow needs to be where it's going. Again, on the bottom right picture, if you're in a gym or a facility where the monitor is mounted high or even on the ceiling, it's going to push you in this head back position where you can't even catch your breath while you're trying to exercise because you're in the wrong head position. Next slide. Recovery is really important, and some people like to do their legs on the wall to kind of help get the blood flow and the fluid back down. My daughter actually hated doing this when her POTS was really bad, but now that she feels better, she chooses to do this. So I think it's all, again, where you are in the process. Next slide. So if I had a special hat that I wore, it would be a police officer's hat that had a quality control monitor on it. I am an inspector at all times. I look at movement control. I look at the way people move. I go right for the hot spots of where the problems are. So the position that you're exercising in and the posture that you're in that position, whether it's lying down, sitting up, on your hands and knees, wherever you are, it's really, really critical. Your breathing pattern is really, really important. You need to breathe with your diaphragm, not with your upper body muscles. Symptom regulation is the dimmer switch. You need to be able to turn it up and turn it down. If you can't turn it down, you're not going to succeed. If you can only turn it up, you're only going to shove it all the way up and you're going to be at 10 out of 10 symptoms. That's called dosing. So aligning yourself with somebody that can help you figure out the right intensity and the right dose of exercise is critically important. Next slide. If you can just populate, there's drop downs that are going to go, just go ahead and do all of them. Thank you, Kirsten. So as physical therapy providers, this is what we do. We look at all the different systems. We look at endocrine, musculoskeletal, your joints. We look at your skin integrity, which of course with EDS, bruising and different things can be an issue. We look at your cardiovascular status, your pulmonary status. It's what we do. We do look at the evidence of what's out there to try and ideally help you. So if you have a physical therapist in your area, I'm going to give you some slides here in just a second that can help you find a PT in your area. Go ahead, Kirsten. So this is just principles of neuroplasticity, which basically is the fancy word meaning you can get better because your brain is neuroplastic. You can get rid of maladaptive behaviors. You can reset your autonomic nervous system. I do not have a crystal ball to tell you how to do it or how long it's going to take, but it does happen. And these are the steps that are really important, that you do have to get up and do something. It just might mean changing the position you're in. It might mean being in a zero gravity chair instead of a bed all day. It depends on where you're starting from. You absolutely, I'm going to skip all the way down to the one where it says salience matters. Salience means it's meaningful to you. It has to be something you want to do. So if you have a passion for any form of activity, no matter what it is, figure out a way to make that your exercise. Make it fun, make it enjoyable, make it something that means that you want to be better and to get back to your life. Next slide. You have to go slow. This is a marathon. It's not a sprint. I think most people that are here for this webinar understand that. But if you happen to be new to our group, welcome. We love you. Ask questions. It's a journey. It's a lot of trial and error, and you learn from the error. Next slide. Use your resources as best you can. Things are costly. They take time. You might have other roles in your life that you have to attend to. And if you haven't read about the spoon theory, you need to look it up. So figure out how to use your resources. Next slide. So finding a physical therapist. There might be a category on here that speaks to you. If you are worried about cervical spine instability because you know that you have hypermobility issues, then that might be a hot topic for you. If you have chronic pain, doesn't matter what part of your body it might be in. If you've had a concussion and either you had POTS first and then you passed out and fell and you got a concussion, or if POTS started after your concussion, it doesn't matter, chicken and the egg. If you feel like you just have dysautonomia and not POTS, or if you just want to use the word dysautonomia, POTS is just a flavor. Again, hypermobility. If you have pelvic floor issues, if you know about vestibular rehab and you think that it's more of a sensory processing issue, Google physical therapy and whatever your hottest topic is. Pick one thing that's the most problematic to you and see if you can find a provider in your zip code area that has maybe some expertise in this. And then cold call. Call them up and say, hey, do you do this? Do you have a person on your team that is familiar with any of these words or has experienced any of it or is willing to learn with me? And do you have two providers that maybe like one of them does neck and the other one does concussion or whatever? Can I come and just meet with you? And you don't necessarily have to have a scheduled appointment. Most insurance companies will always at least cover an evaluation, especially even Medicare will always cover an evaluation. Next slide. Most states also have direct access, meaning that you don't have to always have a physician referral to go to PT, physical therapist, or primary care providers. We have a doctorate degree of training. You can go to the American Physical Therapy Association and use their Find a PT tool, and you can try and at least couple that with a Google search and find out some people are specialty certified, so you might be able to see a little bit more about what they do. There's also the Vestibular Disorders Association that has a provider network that you can look up if you specifically want to know about central processing and dizziness and balance. Then you might find somebody in your area that works through VITA. Next slide. Again, for success, I'm just going to say you have to be willing to partner with people. You have to be willing to kind of sometimes take the lead. I will tell you that I have learned more in my entire career. I've been practicing for over 25 years. And the people that I have learned the most from are my patients and my kids who have taught me about what this is all about. And so if you can find a provider that's willing to listen and learn, and I am willing to mentor anyone, so feel free to introduce your providers to me online or however, and I'll be happy to help. Next slide. And then just finally, this is hard. This is really not easy. It's not a one-size-fits-all program. I told you at the beginning that I can't tell you what to do in 45 minutes because you're all unique and you're all different. You have to decide at what point you want or need guidance and who you want to try and get that guidance from. If you're stuck, there is a reason. You just haven't figured it out. And somebody needs to help you look at the cause and effect relationships to figure that out. I did add, so my slides are going to be available. I did add that link onto the bottom of this slide and it's not populating, so I don't know why that didn't show up, but you will get my slides, and my slides have a lot of added text on them so that you will remember what I talked about today. Next slide. And so thank you very much for joining us today. There's some information that you can access through Dysautonomia International, and I'm honored to be here today. And I really want to thank everybody from the Possibilities Parents social media groups and the Colorado chapter. You guys are all amazing and super supportive. And I know what I know because I've traveled this journey with all of you, so thank you.
Thanks so much, Nicole, for a really, really engaging, helpful talk. I know that exercise is one of those things that every doctor tells us to do, and it's just really hard for a lot of people. And it's nice to hear someone acknowledge that, who is a specialist in, helping people with various ailments kind of try to do their best with their exercise that they're able to. So we can take a few questions. I know we started a little late, so if you have a few more minutes to hang out, Nicole, we could just do
I'm fine.
The questions. So everyone on your control panel on the left side, there is a place to type in some questions. So keep in mind, there's, like hundreds of questions already in there. so we're not getting to all the questions, but let me just kind of scroll through quickly, and please keep your questions to things that are like, generally applicable to a lot of people rather than a individual personal medical advice kind of question.
Lauren, while you're scrolling, I'm just going to reiterate that on my handout that you will have access to, I really put a lot of information on each of those slides that have all the pictures about what the left and the right pictures showed, good or bad, about the spine posture and the different things that you can do, and some tips on your, so if you were trying to take copious notes, rest assured that I typed it in for you on your handout.
Okay, and we will make sure that everyone gets access to that. And we post our, it'll take about a week. We post our webinar videos on our Vimeo page, vimeo.com/dysautonomia, which we call our autonomic disorders video library. And we will post the link to the slides with the video. It's a little short bit.ly link. So once it's up on our Vimeo page, then we share on social media, and sometimes it goes out in an email blast. So everyone will be able to have access to this. Okay, so really great questions. This one I went through personally myself, so I know it's such an important question. What is the best type of PT to start with when you were totally bedridden?
So I actually had this question from a PT the other day asking me, what do I do with my bedridden patient? So I actually recommended telehealth, and I recommended that the patient try to see. So you could also do home health, depending with COVID right now, whether or not somebody's able to come to you to do home health or to do a telehealth visit. And if you were able to, for that first session, you could just have your screen on and show them what you can even do in bed. I mean, if you're really, really, really bed bound and you can barely move, then we need to be working with you in bed. Frankly, I mean, we got to meet you where you are. We can't get you out of bed to come to the clinic if you're in bed. So being able to do some very gentle exercises, and it would be helpful if you happen to have a friend or loved one or family member that can be present so that they can help to even take notes or physically help you move parts of your body if you can't do it on your own. So that's what I would do, either home health or telehealth.
There's some tips on our website, dysautonomiainternational.org/exercise, which is on this screen right now, that we have, it's sort of informal, you know, it's not a officially PT guidance or anything, but some ideas for people, you know, in terms of meeting you where you're at. You know, if you're bedridden, here are some just movements. You know, I think as patients, a lot of people hear the word exercise and they go, oh God, I can't exercise, because they're thinking of a sweaty, intense workout or a 5K jog, you know. And exercise is whatever is moving your body a little bit more than you're currently moving it.
Right. I mean, really simply rolling over in bed stimulates your inner ear tremendously. So practicing once every hour, rolling and rolling, is the beginning of recalibrating your inner ear so that it knows when you're moving. If you're
Yeah.
laying in one position all the time, everything just kind of shuts down. And so you have to give your brain some feedback so that it can start to reprogram itself.
I was bedridden for about 2 years before I was properly diagnosed and treated. And to take myself from that sounded funny, bedridden, not bedwetting, bedridden. I'm like super brain foggy today. I don't know what's going on. From bedridden to I'm actually back to like snowboarding and surfing, like the extreme of, you know, health. To be able to do that took me years, and starting from the bedridden point was the hardest point. And so I used to just sort of challenge myself to do little silly things that no one else would consider to be exercise. But like if I was watching TV, I would get up during every commercial and like walk across the room. Or as I got a little stronger, I would walk a loop around the house. And then, you know, once I got strong enough to do that, I'd be like, okay, I'm going to do a loop around the house and I'm going to do like 3 sit-ups, like just like really, really minimal stuff that was at the time extraordinarily difficult for me. And then I upgraded to, I decided to do Wii Rock Band rehab, like on my own. I was like, oh, I can play the drums, which is all 4 limbs, you know, and you're listening and you're moving and you're breathing heavy if you're trying to play Ringo on expert level when you're doing Beatles Rock Band. so anyways, but exercise to you is whatever is fun and helps you, you know, do something more than you're currently doing. Okay,
that salient piece.
Next question is, do you have any suggestions about breathing exercises?
So, I mean, there's again a ton of online resources for different types of active cycles of breathing, different breathing techniques that are endorsed by different groups. You can look at lots of them. I mean, I could probably do a whole separate talk just on breathing. But that's really what it needs to be. Some of it starts with just being in different positions, lying down, sitting, and standing, and being consciously aware of how you breathe. Even video recording yourself and figuring out how you can change the way you breathe. So for example, if you were to lay in your bed and you had a bag, like a pound bag of rice, if you put the pound bag of rice on your stomach, does it have any impact on how you breathe? And then if you put the pound of bag of rice on your upper chest, does it change how you breathe? And so it helps you because that's a weight that's on you, and you have to move it by either breathing in your upper chest or breathing in your stomach, and figuring out where your breathing starts from, and working on doing the things like breathing in through your nose and out through your mouth, nice and slow, and counting like how many seconds on the inhale and how many seconds on the exhale, and lots of different work looking at breathing patterns. And so, trying to do that with exercise. Everybody holds their breath when they exercise. It's the first question I ask everybody when they start an exercise. I say, "Are you breathing?" And they go, "No."
So here's a question that could be an entire lecture in itself. What types of things do you recommend to help normalize sensory processing and reduce hypersensitivity?
So it's a graded exposure program. And yes, that could be a whole extra talk, but you have to, again, it gets back to that dimmer switch, like what can you do to turn it all the way down? So if it's hypersensitivity stuff, if you're in a dark room, quiet room, are you okay? And how can you start to add one element of sensory exposure, and how can you do it for 30 seconds and tolerate it, and then do it later again for 30 seconds, just like Lauren was just talking about with her experience. It's a graded exposure reintroduction so that your brain can tolerate it. Basically, all these things that people are talking about as their symptoms are, your brain is not supposed to experience any of that. You're just supposed to be kind of blissfully unaware, like no headache, no dizziness, no nothing. You're supposed to walk through life totally fine. And that is what happens when your autonomic nervous system functions properly and when all of your other sensory organs function properly. But when they don't, it's like your circuit system, your motherboard is like overloaded and there's short circuits flying everywhere and you can't get any control. And so you have to only expose yourself to kind of one small thing at a time, and you have to be in a position that allows you to do it. So for example, at the clinic that I used to work at, we had a room where we kept a disco light, and we would put people in the room and flip the light on, and the goal was to make it in there for 10 minutes. And you might start out sitting in a chair with your back up against a wall and be nauseous after 30 seconds, but then you'd have to be in the room doing different activities in the room while the light was going around and you were standing up. You might have to stand on a foam pad and not let the impact of the disco light push you over. So graded.
That sounds like graded torture to me, but you know. The next question, I think this probably be our last question. We'll probably try to wrap up around 8:20 Eastern here. So this person is reporting something that I hear a lot of patients talk about. She says when she has a long conversation with someone, she gets extremely lightheaded, and if she starts laughing, or sometimes I hear people talking about this with singing. Is there anything you can do PT wise to try to help address that?
Yes, that again is tied into breathing. Very tied into breathing.
Yeah, I actually think I think that there are probably respiratory issues in autonomic patients that are very poorly defined. We have a lot of research looking at heart rates and nervous system function, but not really too much stuff on pulmonary function. And there's definitely some wonky stuff going on in some of our patients. Okay, so that one was quick, I guess. I
can do a whole talk on that as well.
You can do a whole lecture on that too. Yeah. So do you have any, there's a specific question, but I'm going to ask it in a more broad sense because I see it all the time. So there's some doctors that think you should not be on medication if you're doing the Levine protocol or like an exercise rehab. And there's other doctors who say, no, actually going to give you medication so you can actually do the exercise. So is there a consensus in the PT world about this? And does it is this a question beyond dysautonomia? Like, does this happen in other diseases too, where there's this kind of debate about whether you should be on medication or not during your rehab?
Yeah, and I'll give you the prime example that I'm familiar with really is with dizziness. So we have people that go on vestibular suppressants so that they're not so dizzy. So they might take something that's called meclizine, which is similar to Dramamine over the counter. And they'll say, oh, I feel great because I took my meclizine. Well, now their brain is just dulled. And so they can't feel the dizziness, but it's not helping them adjust their vestibular system so that the dizziness goes away. It's just band-aiding it. And so, or other people will wear scopolamine patches like you get when you're on like a cruise ship to get rid of motion sickness. And then we have to get them off of the patch so that we really know how they're responding. So sometimes we'll cut the patches down. So I personally think it's probably the same way with different medications. It's, we usually get the patients after they've already been medicated. So we're not part of that discussion. And I think it makes it cloudy about how you're going to do your rehab. And what you're really looking at is the person on a beta blocker or not. What is their response to exercise based on what medication they've been put on? And I think it's kind of hard to know. I think a lot of this is still shooting in the dark. I think that what we see with a lot of the medical management of POTS and dysautonomia is there's kind of a series that you go through. Like first you try the hydration in the water, and then there's like a progression that you go through with the medications of trial and error, like what works for you. And you don't know until you start trial and error. And depending on who your providers are, your trial and error starting points might be slightly different. And so in PT, we don't really get to make that choice of the medication. Sometimes if you have a good relationship with a doctor, they might ask for your opinion, but it depends on if they're already in PT or not before that decision is being made. So we more have to react to it and then help try and wean off. I mean, our goal always is to wean off the medication if we can and get a more natural response from the body.
Yeah. My own experience, not that it's universal, there's plenty of people with totally different experiences, but I really couldn't exercise without taking Zyrtec beforehand. I was having the sort of mast cell stuff. This was when I was really sick in the beginning. And now I'm fine. I don't need to do that, but there was some benefit to me, like to be able to, I figured it was better to do exercise on medication than to not do exercise at all, which is what was going to happen if I couldn't take the Zyrtec. So I also think it depends on your goal too. Like if you're trying to build your blood volume, which is one of the benefits of exercise that's very important in dysautonomia patients, since we tend to have low blood volume. Being on Florinef and IV saline is not going to help you build your blood volume. It's actually going to do the opposite. It's going to make it harder for you to naturally increase your own blood volume through exercise. Right. But that does not mean that you have to be off those treatments to do exercise. Of course not. Some exercise is always better than none. But right. If you're like looking at your outcome as what is the ultimate goal of this, maybe it's starting your exercise on whatever medications you're on, and then like over time when if you're feeling stronger, if you're feeling like you have a little more tolerance of exercise, talking to your doctors about trying to do it with like less medication as your first step, and then maybe with no medication. And it's, in my perspective, it's okay to be on medication. It's not like a bad thing, but I think a lot of us are put on a lot of different medications by different doctors who aren't talking to each other. So we hear all the time about, like 14-year-olds who show up and they're on like 17 different heavy hitting drugs because they had seen 17 different doctors who didn't even look at what else they were being given. And there's so many, concerns about that in the long term. Like, do we really want to be on that much? And some people have to though, so.
Right. Well, and I think that my older daughter, she failed at exercise for probably 3 solid years. And the only medication that allowed her to finally exercise was being on the extended release Mestinon. And nobody yet can explain to us why. And now she doesn't need any. She woke up one day and she literally said, oh, by the way, I stopped taking it. I felt like the side effects were worse than what it was doing for me. And now I don't think I need it anymore.
Oh, yeah.
And of course we told her, there are some medicines you're supposed to wean off It would be helpful if you let us know when you're doing
Yeah,
that. But she doesn't take any, well, she takes her antihistamines, but
yeah.
she doesn't take any of those other medicines.
Someone actually just made a comment that it's a good, very good point. We're talking very generically here. Dysautonomia itself is not a diagnosis. It's sort of a big umbrella of a lot of different autonomic disorders. And someone said, I was told by my doctor I couldn't start the Levine protocol until my heart rate was under control because this person has inappropriate sinus tachycardia, which is a dysautonomia-like or type of dysautonomia, depending on who you ask. But the doctors kind of have some disagreement on that. But it is present in a subset of people who have POTS and orthostatic intolerance, and it is not a positional based tachycardia. It's just sort of a more constant tachycardia. And so, yeah, it would be really hard to do cardiovascular exercise if you already have tachycardia, even just laying down. So
Right.
that it's important to just realize, like, we're kind of speaking generically, and of course, whatever your doctors have told you is what we're encouraging you to do. So let's do one last question, and then I guess we could probably wrap up. So are there, can PT help? Are there certain things that people can do who are having, stability, hand control type problems, like where they're feeling shaky or they're having trouble with writing? I think your answer is probably yes. Like PT is for
Yes.
part of
So
your
that would
body.
fall under the wheelhouse of a movement disorder. And so that is poor coordination that could come from lots of different things. The other words that are used to describe that would be either like an ataxia or a dystonia. And so, yes, we do a lot with that. You would probably have to find somebody that has neurological background or experience treating that, but that's very, very common. And there's lots of different reasons for that. So yes, that could be treated by PT.
Speaking of finding a provider, a PT type provider, or really any provider, I want to encourage everyone to join our Dysautonomia International support groups for your region. We have support groups in almost all 50 US states, a couple Canadian provinces, a couple other countries. We have the main POTS group, which is international. Join the groups, and each of the state and province and country-based groups has a list of providers pinned to the top of the Facebook page. And you can say, I saw this physical therapist in my hometown who was amazing. Here's their name, here's their website. Because that's really one of the most valuable things about the support groups is talking to local patients who say, this is who you see in Tuscaloosa, and we can also tell each other, like, who maybe you want to avoid. But mostly we're trying to find people who are helpful, and then the people who are helpful to us aren't necessarily always the big famous experts, right? There's plenty
Right.
of hometown local doctors who are just compassionate and willing to learn and wanting to help, and we just have to help each other find those people. So Nicole, thanks so much. This was
Yeah.
really great. I'm sure a lot of people learned a lot. There's a lot of very positive feedback in the questions for you, just saying thank you so much, really great. And so I guess do you have any final parting words for us?
Just keep your hope up. It really is a long journey. You'll learn a lot about yourself. And, some of these situations for some reason make us smarter, better, more aware. Be your own private investigator of your own body and team up with somebody to help you. I wish you all a lot of luck.
Great advice.